Nitrous Oxide by the Numbers is a brief program designed to refresh your training or provide a basic understanding of nitrous oxide, analgesia, and sedation. You can always reach me through my personal email or cell. Feel free to call, feel free to text, and if I don't respond within 24 to 48 hours, please send a card or flowers. So you don't have to be an expert to have an opinion, especially when it comes to nitrous oxide in dentistry. And there are a lot of opinions. The ADA currently recommends approximately 14 hours of training. Many states do not require a dentist to have a permit, while at the same time requiring the hygienist to have one. I really hope I don't offend anyone with the slides or comments that I make. I do not have any financial or commercial interest in any of the products shown in the program. All of the slides are authentic and they're all unaltered. I would like you to take a moment to read this slide. Pause the program to look it over. It's not meant to scare you, but to encourage you to participate in other nitrous programs, especially programs on handling office emergency. Since this program is about a half hour, you will have limited knowledge in providing nitrous oxide sedation and analgesia to your patients. A little about me and my background. I graduated from a foreign dental school in Buffalo, and like you, started off my professional career with minimal training, and most of it was didactic. Then I went off to a general practice residency. There we had portable nitrous units that could be brought to every dental unit. Then one night the chief of our service returned to his office to find one of the residents administering nitrous oxide to his date. The next day and from then on, all the units were locked up. After my general practice residency, I finished a residency in dental anesthesia and have been teaching sedation and anesthesia since 1984. Upon completion of my anesthesia residency, I purchased one of the anesthesia machines from the operating room and I started passing gas in my private practice. Then one night, shortly after opening my practice, I returned to my office and found my office manager unconscious on my anesthesia machine. We never spoke again. So what is the point? The point is everyone's training from the student to the veteran about to retire is different. How did the ADA decide on 14 hours of suggested training or the number of cases to administer to show competency? I've got no idea. Even during my general practice residency, the training was probably under an hour. During my anesthesia residency, my training in nitrous oxide was probably contained in a book we had to review. When I was asked to help with the nitrous course offered by Temple University, I went ahead and read the book, I watched the movie, and while reading the book I found this evaluation form that we use, and we end up going over 3 cases together. That evaluation form came out of this book, and it's version 5.0. Ironically, the same typos and slight misinformation that was in the textbook was also used in the ADA guidelines for sedation and anesthesia, and then again in the latest regulations for sedation and anesthesia in New York. I'm pretty sure this course didn't take 4 hours to complete when it was released. Also, many of the other online programs I found were under 2 hours. I like the shock and awe value of this slide, and I doubt you'll never forget this face. This case was published and given to me by my friend Dr. Robert Bosak. Dr. Robert Bosak also created an online course for sedation and anesthesia training, along with emergencies that you can use for additional training. This is probably the most common way offices have been administering nitrous oxides since before my time in 1978. What has changed is the newer state-of-the-art materials. Keep in mind when utilizing nitrous oxide, you have created an oxygen-rich environment. So while cutting off this anterior zirconia crown, a spark was generated and that caused the explosion. So what's the answer? How do you prevent this from happening to you? You can send them to your specialist friend to remove the zirconia crown, or you can remove the hood from the patient. Turn off the unit and use a generous water spray. Anything you place in or around the mouth has to be damp and water soluble. For example, KY jelly is water soluble. Vaseline is not water soluble. And if you like, pause the program to read this slide and take a photo. This is an example of why I suggest you have additional training before administering nitrous oxide to your patients. On a Saturday night, I received this image from my former hygienist. Her good friend took her daughter to have her 3rd molars removed, and the oral surgeon placed her on nitrous oxide. She immediately broke out in a rash. He then canceled the procedure and referred the patient to an allergist. Here's a photo of the young girl's back. And now you can see how extensive the hives were. Keep in mind, nitrous oxide is an elemental gas. You really can't have a reaction to it. Also, after treating thousands of patients in the operating, some of which had some serious medical problems, it was fairly common to see this reaction. It was mostly across their neck and chest. The solution is to treat their nerves and anxiety. I suggested the oral surgeon give a dose of oral Versed 30 minutes prior to treatment to calm her down. Every office I visit is different, and sometimes it takes me a few minutes to understand the system, but the following basic principles always apply. You have blue tanks and green tanks, small tanks and big tanks, a central supply or portable units. The take-home note is the green oxygen tank is the compressed gas with a full pressure of between 1800 and 2200 psi. Your blue tank is a liquid similar to the propane tank you have in a barbecue. The pressure will remain at 750 psi until you have less than 20% of the volume. What does it mean for you? It means that the oxygen tank is like your gas gauge in your car. It gradually goes to empty as you use it. The blue nitrous tank is like the gauge in my old 1989 Bronco. It doesn't move until you're near empty. You will notice that this setup has 4 tanks. There are 2 green tanks of oxygen and 2 blue tanks of nitrous oxide. It's set up that way so if your green tank is low, and I mean low, not empty, you can switch over to the full tank. The blue tank can be switched over when the gauge goes below 750 psi. Question: what color is the oxygen tank, and when do you know it's full? A, white and can hold up to 3000 psi like a scuba tank. B, blue and will remain at 750 psi until empty. C, green and hold approximately 2000 psi when full. I will ask you this question and would like to remind you that the exam questions upon completion of the program are based on the understanding of the questions asked during the program. If you got this question wrong, you should probably watch the last few slides over with a strong dose of caffeine. The correct answer is C. They are green and hold approximately 2000 psi when full. When you receive your tanks from the supplier, hopefully you will see at least 1800 psi, and often full tanks may have 2000 psi or just a little bit more. As you use the oxygen, the pressure will drop until empty. Your supplier may be upset with you if you run them down dry to empty. They like a little bit of pressure to keep the atmospheric humidity out of them. Nitrous tanks are blue and they have a pressure of 750 psi. Modern scuba tanks can handle 3000 psi of gas. Nitrous oxide tanks, A, are blue in color. B, the pressure gauge will remain at 700 psi as long as liquid remains. C, utilizes a pin indexing system for safety. Or D, all of the above. Yes, the tanks are blue in color. The pressure of the gas above the liquid phase will always remain 750 psi. One of the fail-safe mechanisms is the pin indexing system on the head so the gases cannot be switched. It is impossible to mix the tanks up and have that mistake. So the correct answer is all of the above. It is cost-effective to have a central supply of gases. The gases are supplied from a remote location, and the green oxygen hose has a unique connection to the wall, as does the blue nitrous hose. It's a good idea to periodically take some soapy water in a spray bottle and check the hoses and connections for leaks just like you would a raft or a nail in your tire. Nitrous oxide tanks. A full tank pressure gauge will read 750 psi. B, after 30 minutes of use, the pressure gauge will read 650 psi. C, at 70 degrees and 2 hours of use, the pressure gauge will read 750 psi. D, when the tank contains less than 20%, the gauge will remain at 750 psi. Or E, A, and C. This question should be a gift. The only trick answer is C. Temperature does have a small effect on the psi of the gauge. It's only during extreme cold or hot environments. When would you see this? Well, you would see this if your nitrous and oxygen tanks are placed in an equipment locker. And that's a really bad idea to do that. Or if they're against an outside wall and you're having a heat wave or in the dead of winter. Yes, I've seen tanks in the equipment closet, and that office was actually built by a well-known dental supplier. Kids don't know how to get high. They have different levels of maturity, and typically kids under 6 are more challenging than those over 6. So here is a case of a child who went to a dental clinic, determined that they had decay, was referred to a dentist who had nitrous oxide. They practiced for a little bit, and then when they put the nitrous oxide on the child, he didn't cooperate, and the dentist went ahead and slapped the child, and it didn't end well. We will cover the textbook contraindication of nitrous oxide in sedation. There are 2 absolute contraindications you will encounter. The first is pretty obvious. They need to breathe through their nose. If they can't breathe through their nose, you can't administer the gas. So it can be any form of obstruction, from an upper respiratory infection to a deviated septum causing the blockage. The second is a concept you really need to fully understand. If they have a confined space or bubble, since there is no nitrous oxide in the body, the gas will rapidly enter the body cavity or void and quadruple in size. This typically results in nausea and vomiting, and you'll see this after a patient has a fatty meal. Another textbook example is a patient with an air bubble intentionally injected into the eye for detached retina. Diffusion hypoxia is another theoretical problem. This is when you or your patient suddenly removes the nitrous hood. You know not to do it, but your patient may panic and become confused and grab the nose piece and remove it for you. This often happens with special needs patients under nitrous oxide. When the hood is suddenly removed, there is still plenty of oxygen in the lungs, and it won't be displaced by the nitrous diffusing back into the lungs from the circulation. Oxygen drive. A patient on oxygen drive is not coming to you. They are currently at hospice or ICU and currently not leaving the hospital to come to you as a dentist. The last point is the elephant of all points in the program. I would like you to repeat this over and over again. Nitrous oxide potentiates everything good or bad. For example, if they are a good drunk, they become a cooperative patient. If they're a bad drunk, watch out. Caution your staff. Bad drunks under nitrous oxide exhibit all the bad things you can think of. Inappropriate behavior, unwanted physical contact, and then they have excuses for not behaving or following the rules of good conduct in your office. Another real important note is it potentiates all medications. You really need to be concerned if you're giving a patient a sedative or if they self-medicated with products like THC. A huge red flag is gummies or those that are on benzos. That includes Xanax, Ambien, Halcyon, any type of sedative hypnotic. They can go from minimal sedation with nitrous to potentially deep sedation and unconsciousness. You will unlikely see a patient with an air bubble in the eye. They tend to present with an eye patch. If they've had eye surgery or problem with their eyes, it's probably a good idea to reschedule the patient. Either the air bubble will enlarge from the gas that you've given them, or the nitrous hood will touch the injured eye or the infected eye and cause more damage. When I first noticed the program advertising these highlighted objectives, I really had to take the program. Here's a word of caution. If you see this, remember what your mother always told you. If it sounds too good to be true, it probably is. I'm still looking for the solution of when a patient says to you, I don't feel it yet. If a patient tells you, I don't feel it yet, either you have a gas leak, which is possible from everything from a poor nose piece fit to the system leak. There's also the chance that your patient has a huge tolerance to all sedative hypnotics, including alcohol, and you will unlikely never have enough gas to get them to stop saying, I don't feel it yet. If your patient says to you, I don't feel it yet, cranking up the gas to over 50% is not the answer. You first look for an obvious equipment failure or fit issue, and if it's not a leak, stay with the 50% and have them stop talking and just breathe the gas. Employees will always be concerned. Reassure them that nitrous oxide is heavier than air. Work with a scavenger and make sure that the exhaust gases are going outside the building or to remote locations. In a perfect world, you should have a disposable system. I presented the idea to Crosstex to use a disposable system I designed, and they loved the idea. Unfortunately, I kept the original 2-holes design and got into the nitrous business and never used my concept. My concept was not only disposable, but solved the limited visibility and restricted head movement with the current designs have. You will always have administrative worries, and you'll always have to maintain your equipment. So nitrous oxide possesses a minimum alveolar concentration of MAC of 104%, abused by dental healthcare professionals to lock it up. Scavenging is essential during sedation. staff member in the room at all times. We covered these in detail, but I just want to go over two other topics. You as a non-anesthesiologist should limit your maximum nitrous concentration to 50% or less. The MAC, the mean alveolar concentration to get general anesthesia, is 104%. It does have the potential to be abused by healthcare professionals and our patients. Many cannabis retailers are now selling nitrous oxide. Even Amazon is selling nitrous oxide. And if you don't believe me, go Google and look up Galaxy gas. Check the system you're using and check the suction pressure of the scavenger. I will always keep a staff member in the room at all times with and without gas if it's in play. And that's my practice management tip for the program. So nitrous oxide will help your fearful, anxious patient. Keep in mind you're bad drunk, maybe not such a good idea. Many of your patients, and the majority of your patients who want nitrous oxide, just want it because they like to get high and will request the gas. It's no different than going out to dinner, having a drink or two to tolerate the company you're with. I would suggest you have practice sessions with a child that may be nervous. Those having chemotherapy, or those that have methyl ethyl tetrafolate reductase deficiency, that is something that you'll find on their medical history, and that's something you need to talk to their specialist. Use of nitrous oxide. I can't stress enough that children don't understand how to get high. Don't refer to it as a mask. Parents of a child will often suggest its use because they like to get high, and you can only use it in one direction. If you try using local anesthesia and the patient becomes uncooperative, throwing nitrous oxide is not going to be your answer. But if you have an anxious patient, start with the nitrous oxide, let them experience the nitrous oxide, and then work your way on to local anesthesia and giving pain-free dentistry. Try to leave it on for a few minutes, maybe up to 5 minutes with a little bit of topical. Nitrous oxide is not metabolized and has a rapid onset. As I mentioned earlier, it is a supplement for oral sedation that will potentiate any medication that's in their system. I like using about 30% on my pediatric patients, but you can go up to as high as 50%. The patients must always be attended. Like motherhood, a scavenger system is something you must have, and make sure it's vented outside the office. Always work in a well-ventilated area. Don't refer to it as a mask, and encourage your patients not to talk. I use a rubber dam, or you can use an isolate. By using a rubber dam or isolate, it does force your patient to breathe through their nose. Is this statement true or false? Nitrous oxide analgesia has no effect on the action of oral sedatives. As I mentioned earlier, potentiates all medications. You have to be concerned if your patient is already taking a sedative hypnotic or is self-medicating. So this statement is false. Nitrous oxide given to a patient already taking a sedative like Xanax, Ambien, Benadryl, gummies, or THC. They could be vaping, maybe they went out and drinking and had some alcohol. It will potentiate that response. Nitrous oxide is a minimal sedation technique. Many states do not require a permit for minimal sedation, but nitrous oxide in combination with any other drug may be considered moderate sedation with the potential for deep sedation or even general anesthesia. As a caution, keep in mind older patients are very sensitive to nitrous oxide, and nitrous oxide in combination with other drugs will really hit them hard. Nitrous is a drug, and we are talking about a single drug technique in this program. I like to work a little tell, show, do into the way I manage kids. Here I have Crocodile Dentist. I buy them by the case from eBay, and every child is met in the reception area and gets to play with this toy. We discuss opening wide, staying open, and allowing me to count your teeth, and remember, no biting. Then we work the nitrous oxide sedation into the plan, and the child still thinks he's playing the game with me. Tell, show, do is critical to success. It's a form of pediatric hypnosis. Not only do we play Crocodile Dentist, but we also play with the nitrous hood. I personally never refer to it as a mask. I also have the parent and guardian demonstrate how it's worn, and then we practice whenever possible before we actually have to render care. Take-home points. Have the patient avoid speaking or talking. Never flush the bag. Put them on 100% pure oxygen for about 5 minutes before you discharge the patient. And have practice sessions whenever possible so they can experience what it feels like to be under nitrous oxide. You've now made it through the program, and here's your final question. You shouldn't flush the bag because A, it pushes dust and debris up through the nostrils and into the lungs. B, sends waste gas nitrous oxide into the operatory. C, could pop the balloon with a loud bang, startling your patient. Or D, you should flush the bag to speed up recovery time. The correct answer is B, sending unnecessary gas into the room. Your equipment should be clean and dust-free, so hopefully you won't be pushing junk into your patient. Unless the edge of the hose is plugged off, the bag will not pop. You should regularly check the bag because you frequently disinfect it and it destroys the material. Place your patients on 100% oxygen to help speed up recovery, and it gets rid of that tired, disoriented feeling that patients may experience after being on nitrous oxide for a period of time. Once again, thank you for your support and confidence in me and my programs. Have a great day today and every day. Thank you for watching this brief video. Please click on the like button, subscribe to my channel, and feel free to leave a comment. I usually respond to comments in 24 to 48 hours. Have a great day today and every day.